All right, welcome everyone. We have got 7 or 8 students now, and the other students will join slowly. So we will start with the lecture. And let me tell you that this is a very important lecture, and you must pay full attention, and you must prepare this lecture well for the examination. This lecture will be included in the midterm examination, all right? So I'll share the screen with you, and then we'll start with the lecture. All right, so I hope you can see the screen. Please say yes if you can see the screen.
Yes, doctor.
All right, thank you very much. So we are going to start with bacterial pneumonia, and this is a lecture on the lower respiratory tract infections. Now we have got bronchitis and bronchiectasis, some other diseases as well that we are not doing. We will only do pneumonia because this is the most important topic. And this involves pretty complex treatment as well, and also a lot of different organisms that can cause pneumonia. And pneumonia can occur in different settings. For example, we have got community-acquired pneumonia, we have got hospital-acquired pneumonia, we have got ventilator associated, so many different settings. And a little bit of pathophysiology is also important. So this lecture has got on the handout, you'll see 70 slides, but there are a lot of slides that are for your reference when you go to your internships, okay? So it's about 50 slides, and out of those 50 slides, we will decide for the examination whether we want to have the treatment part or some other important parts as well. That we will decide later on. So let's start with bacterial pneumonia. The definition of pneumonia is that pneumonia is an inflammation of the lung parenchyma of infective origin. That is alveoli rather than the bronchi. Okay, so I'll just show you what I mean by parenchyma. By the way, anybody knows what parenchyma is? Every organ in the body has a stroma and a parenchyma. Anybody knows what it is? All right. So parenchyma is the functional part of the organ. You know, the organ has got cells, and the cells are kept together by certain intercellular structures, or you can call extracellular matrix. So the structures that keep the cells together and that give shape to the organ is known as stroma, and the actual cells that function for that organ are known as parenchyma. I'll show you in a minute what it means in the lungs, okay? So bacterial pneumonia is caused by a pathogenic infection of the lungs. It is a serious public health concern and remains the main cause of death from infectious disease in the world, particularly in old people. You know, old people, very old people, 75, 80, or people above 80 years of age, their immunity is down. In the winters, they get viral infections, and viral infections predisposes them to the risk of developing bacterial infections in the lungs. The most consistent presenting symptom of bacterial pneumonia is cough, productive of sputum. Antibiotic treatment is the mainstay of drug therapy for bacterial pneumonia. And infection by bacteria or viruses is the most common cause. The most common is bacteria, but viruses also cause pneumonia. Although the infection by other microorganisms such as Rickettsia, fungi, and yeast and mycobacteria may also occur, but the most common cause are certain bacteria that I'll show you as we go ahead in the lecture, right? So lung parenchyma is the portion of the lung involved in gas transfer, the alveoli, the alveolar ducts, and the respiratory bronchioles. So, you know, we have got two zones in the lungs, the conducting zone and the respiratory zone. The conducting zone is these pipes, the airways, okay? That is not the parenchyma. So what you see over here, these, all these airways, they are the conducting zone, and these are the alveoli, and the gas exchange takes place through the cells that line the alveoli. And in between them, there is very thin extracellular matrix, very fine, and that is all actually the cells through which the gas exchange takes place is the parenchyma. But inflammation can occur in these septi as well, the parts that divide the alveoli. So parenchyma are these alveoli or the cells that make up the alveoli, okay? Right, so this is an X-ray of the community-acquired pneumonia, and you can see over here, this is the heart, right? And here is the normal lung. You see this lung is normal, filled with air, dark, all that, the dark portions show the presence of air. But what you see over here is in this right lower lobe, there is sort of grayish shadow, which shows consolidation of the right lower lobe, okay? Anatomic and radiologic categorization. Pneumonia is an infection of the lung parenchyma characterized by consolidation of the affected part and filling of the alveolar air spaces with exudate inflammatory cells and fibrin. So what I showed you over here, these alveoli, they get filled with fluid, okay? That is why there is no air in it, because air does not have space to enter the alveoli, right? And when there is no air, then it looks like this, okay? This is known as radio-opaque, a little radio-opaque, not very dense, right? So lobar pneumonia, also known as focal or non-segmental pneumonia, it is an acute bacterial infection associated with fibrinosuppurative consolidation of one or more lobes. Now, fibrin, fibrin is a very sticky site of sticky sort of protein, and suppurative means there is pus or there. So consolidation means inside the alveoli there is pus and there is fibrin, right? Then we have this term bronchopneumonia, infection of the terminal bronchioles that extend into the surrounding alveoli, resulting in patchy consolidation. So patchy consolidation is something that you see on the X-ray, and the radiologist is the best person to read that X-ray or to give his opinion on that X-ray. So it starts bronchopneumonia. It starts in the terminal bronchioles, and then it extends into the alveoli, and that is why we call it pneumonia. Interstitial pneumonia means that the walls of the alveoli and this little bit of this matrix, intracellular matrix, extracellular matrix, sorry, that inflammation of that part. And obviously when the extracellular matrix gets inflamed, then the capillaries are going to dilate, like you have already done inflammation because of release of certain substances like histamine. The blood vessels dilate, and the capillaries also dilate, and fluid leaks out of the capillaries, and then obviously it will enter the alveoli, right? So it affects the septa of the alveoli and appears as patchy interstitial fibrosis with alternating areas of normal lung, right? So you just have to understand that we have got 3 or 4 different names or types of anemia: lobar, bronchopneumonia, and interstitial pneumonia. So this is just a part of pathophysiology that we are doing over here, right? So settings of pneumonia is important. As I said, we have got community-acquired pneumonia, and it has got a definition. Then we have got institutional acquired pneumonia, which includes healthcare-associated pneumonia. Now, what is healthcare? According to Infectious Diseases Society of America guidelines, they call it or they recommend it to be treated as community-acquired pneumonia. Although it could be, old homes and some places like that, they are healthcare-associated places. So this is healthcare-associated pneumonia, and it is included or it is treated as community acquired pneumonia. Then nursing home associated pneumonia, although this is also a healthcare facility, right? So this could also be included in community acquired pneumonia. Anyway, then nosocomial pneumonia, I hope you know that it is also known as hospital acquired pneumonia. The problem is, or why am I showing you these different types of settings? Because the organisms are different in these different types of settings, and the severity of pneumonia is also different. Obviously, it's going to be more severe when it is acquired inside the hospital. Then we have got ventilator associated pneumonia and aspiration pneumonia. Obviously, ventilator, you know what a ventilator is, and aspiration means something going from the GIT into the trachea and into the lungs, okay? So community acquired pneumonia is defined as pneumonia that develops in the outpatient setting or within 48 hours of admission to a hospital, right? So let us suppose many times what happens is that the patients, they go to the hospital with respiratory complaints or cough, sputum, and then you do an X-ray and you diagnose that, which means that when the patient came to the hospital, he already had pneumonia. But sometimes you admit the patient for some for chest complaints or something else, and within 48 hours he develops pneumonia, you diagnosed pneumonia. So that is also community acquired. That is not hospital acquired. Hospital acquired pneumonia has a different definition. Institutional acquired pneumonia includes healthcare associated pneumonia. It is associated with healthcare risk factor, which means prior hospitalization, dialysis with increased risk of exposure to multi-drug resistant bacteria, right? So healthcare associated pneumonia could be associated with places where old people live, or a person who has been previously hospitalized. He was discharged and after some time he developed pneumonia, or he had dialysis because of chronic kidney disease and later on he developed pneumonia, okay? However, as I've already said, that the Infectious Disease Society of America recommend to remove this healthcare associated pneumonia term or category, and it should be treated as community acquired pneumonia. Nursing home associated pneumonia, associated with patient in nursing home and other long-term care facilities. You can include old homes over there. And sometimes, jails or overcrowded places where people live together, that could be included in this. This category of pneumonia has a high incidence of infection with gram-negative bacilli and Staph aureus, which is obviously gram-positive, right? So what we are seeing is that depending on the setting of the pneumonia, the organisms could differ from each other. And I'll show you many slides in which I'll show you the organisms that cause pneumonia, okay? Now, nosocomial pneumonia includes hospital-acquired pneumonia that develops after 48 hours. So in community-acquired, I said that the patient is admitted to the hospital for some reason, and within 48 hours, he develops pneumonia. So that is community-acquired. But if he develops pneumonia after 48 hours, then that's the definition of hospital-acquired pneumonia. And there is a risk of multi-drug resistant organisms in such cases. Then we have ventilator-associated pneumonia. It develops more than 48 hours after endotracheal intubation or within 48 hours of extubation. Now, again, remember the term, the duration, which is 48 hours. So whether to use the ventilator, you have to pass an endotracheal tube. So after you pass the endotracheal tube, or you discontinue the ventilator, remove the endotracheal tube, again, within 48 hours after that is ventilator-associated pneumonia. Aspiration pneumonia develops after the inhalation of oropharyngeal secretions and colonized organisms. So bacteria implicated in aspiration pneumonia are usually anaerobic oropharyngeal colonizers such as Peptostreptococcus, Bacteroides, Fusobacterium, and Prevotellus. Okay, so Prevotella, sorry. So that was about the setting of pneumonia, and here I've given you definition and some more details, and these definitions will be on the test. I've already given you the definition. Community-acquired pneumonia developing in patient with no contact to medical facility, which is outside the hospital or within 48 hours of hospital admission, and then hospital-acquired and ventilator-associated pneumonia. It includes after intubation or after extubation. Both are included in the definition, right? And there, here I have given you the risk factors for all these types of pneumonias. Now, risk factors for pneumonia, extrinsic. What do you think? Extrinsic. Can anybody tell me what is extrinsic? Any extrinsic risk factors coming from outside that may predispose or expose patients to pneumonia? No.
Like smoking, doctor?
Smoking is possible. Yes, you're right. So exposure to causative agents, like, people go for Hajj, and many people, particularly old people, they develop pneumonias because they have been exposed maybe from some other people. Okay. Then exposure to pulmonary irritants. So smoking is included in that, and direct pulmonary injury that are extrinsic factors. Any traumatic injury can also cause pneumonia. Then intrinsic factors are, of course, dysfunction of the defense mechanism. Again, smoking is included over here. COPD, aspiration pneumonia, intoxication, stroke, all these things. Stroke reduces the gag reflex, and that might lead to aspiration. Endotracheal intubation, immunodeficiency, chronic disease, old age, all of these are intrinsic factors. So pneumonia is one of the most common infectious causes of severe sepsis and death. Okay, sepsis is even a more dangerous condition. We'll come into sepsis after 2 or 3 lectures. All right. So untreated pneumonia has mortality rate of 30 to 40%. Now, that means untreated means people don't get any treatment. That happens in poor countries or places where there are no medical facilities available. So who gets pneumonia? Everyone, but pneumonia is much more common in the extremes of life, like very young or very old people. Okay. So elderly, more than 70 years of age, or very young children, younger than 5 years of age, it's more common. Not that other people don't get it, but it's much more common in these age groups. Okay. And obviously patients with chronic diseases as well, like COPD. All right, we'll do a little bit of pathophysiology. This lecture is actually quite a detailed lecture, but I have removed a lot of slides from these lectures. So I've also removed some pathophysiology slides, but there are some important points in pathophysiology that you must know in order to treat pneumonia. That is why I'm showing you these slides. So pneumonia results from the proliferation of microbial pathogens and at the alveolar level, and the host responds to those pathogens, right? So it is the pathogens and the host response. Both are damaging, okay? The immune system, sometimes it responds so strongly that the cause of the damage is the immune system. Microorganisms gain access to the alveoli in several ways. The most common is by aspiration from oropharynx, okay? This gag reflex and these things, as the person ages, or the drug addicts or alcoholics, it's more common in them. Old people, their gag reflex is not as strong as the young people. So aspiration is more common in those people. Small volume of aspiration occurs frequently during sleep, especially in the elderly and in patients with low levels of consciousness. Many pathogens are inhaled as contaminated droplets from other places. Rarely, pneumonia occurs with hematogenous spread. That is, it comes from the bloodstream. For example, if a patient has got endocarditis or contiguous extension from an infected pleural or mediastinal space. Contiguous means direct extension, okay? So, but that is rare. These are the more common causes of pneumonia. So here is a picture. This is normal. These alveoli are normal. And what you see over here is that the alveoli have got fluid in them. Okay, pneumonia causes an accumulation of fluid in the alveoli. So that is why when you do an X-ray, fluid comes as radio opaque or whitish shadow in the X-ray. When there is air, it will be dark. Okay. Right. So this is what happens. And why does this fluid accumulate over here? Because the infection is here in the walls, in the cells, and in the extracellular matrix, in the septa. And when there is inflammation, the capillaries which are present over here, they dilate and they become more permeable to fluid. So fluid will leak out and fluid will accumulate in the alveoli. So increased respiratory drive in the systemic inflammatory response that can lead to because the patient is not getting enough oxygen or carbon dioxide accumulates in his bloodstream. So he starts to breathe faster, okay? And this will lead to respiratory alkalosis, right? He will lose carbon dioxide because he's breathing fast, okay? So that could lead to alkalosis, respiratory alkalosis, decreased compliance due to capillary leak, hypoxemia. Obviously, the oxygen is low because the exchange of gases in the alveoli is decreased. Increased respiratory drive, that is, the respiratory center is in the brain, in the medulla oblongata. So that will be stimulated. It is mainly stimulated by increased amount of carbon dioxide or presence of H ions, right? Increased secretions, occasionally infection-related bronchospasms. Now, all of these, I'm mentioning these because you have to treat all these things in cases of pneumonia. If there is bronchospasms, obviously you'll give bronchodilators. Okay, if there is hypoxemia, you'll give oxygen, right? You have to treat alkalosis as well. So that is why certain parts of pathophysiology are important. And all of these factors lead to dyspnea, which is difficulty in breathing. If severe enough, the changes in the lung mechanics secondary to reductions in lung volume and compliance and intrapulmonary shunting of blood may cause respiratory failure and patient's death. That is how the death occurs in either, there is respiratory failure or the patient will develop sepsis. And then his condition worsens, his organs get damaged, the organs start failing, the kidneys will not work properly, right? And that is how the patient's condition worsens and he dies. Role of viral infection. Now I've written over here for reference only because this lecture is bacterial infection, but viral infection is important to understand because viral infection causes certain changes that can lead to development of bacterial pneumonia. So with the recent SARS-CoV-2 or COVID-19 infection and H1N1 influenza that was there previously, because of these pandemics, it is important to address the role that viral infection have in bacterial pneumonia, right? So viral infection has a role in bacterial pneumonia. Now, what's that role? Viral infection disrupt the respiratory epithelium, providing an opportunistic environment for bacterial infection. So, the cilia, they will not work. There will be more accumulation of mucus that will facilitate the growth of bacteria, right? So there is impairment in the mucociliary escalator. Normally the sputum comes out But here it will come out. People do have cough with sputum, but a lot of sputum is accumulated inside the lungs as well. However, evidence depicts much more complex and possibly synergistic interactions between viruses and bacteria. And these synergistic interactions include alteration of pulmonary physiology. I've explained to you one, which is impairment of mucociliary escalator, downregulation of host immune defense, local immune defenses in the lung, changes in the expression of receptors to which the bacteria adhere. Adherence of bacteria with the help of pili or fimbriae, whatever they cause them to adhere to the cells and then cause infection. So their receptors appear in mucosa or in the cells. Enhancement of the inflammatory process. So inflammatory process is also damaging for the body. Now here in this slide, I'm giving you the typical organisms that cause pneumonia. I'm giving you gram-positive, gram-negative, atypicals, and I'm going to show you a lot of organisms in the coming slide. But these I have kept for reference only because it is very difficult to memorize the names of all the bacteria, but some of them will be included in the examination. So you see S pneumonia is the most common cause. And if you remember, we have done S pneumonia in otitis media and sinusitis. There also, there too, S pneumonia was common. Staph aureus, this E. faecalis and E. officium, and actinomyces israelii, or whatever you call it, nocardia, asteroides, it is misspelled, it is nocardia. This should be a D. All right, so then we have got a lot of gram negatives. Okay, and Pseudomonas aeruginosa, it is more dangerous relatively. A lot of these things, some are common, some are not very common. Okay, but these organisms do cause bacteria. Then atypicals, mycoplasma, chlamydia psittaci, chlamydia pneumoniae, legionella. And then we have got anaerobes that result from aspiration of oropharyngeal contents. These infections tend to be polymicrobial. So we have to give a broad antibiotic coverage. Klebsiella and Peptostreptococcus, Bacteroides, Fusobacterium, Prevotella, all these are included in these organisms, okay? So you must keep this slide, I have given it to you. And you will need this slide when you go to your internships, okay? Then again, I'm showing you these common microbial that cause community-acquired pneumonia, right? So we have got 20%, we have got viruses, 75% are bacterial infection. Viruses are more common in pediatric age group, below 5 years of age. And mixed infections are 25%, around 25%, right? So the common viruses are influenza virus, and uncommon are parainfluenza, adenovirus, respiratory syncytial virus, rhinovirus, whatever, okay? Then among the bacteria, we have got pyogenic, 50% is strep pneumonia, H influenza, staph aureus, gram-negative, 5%, not much. Atypicals are there, mycoplasma, chlamydia, and legionella. So their treatment is going to be a little bit different. We give macrolides or we give doxycycline for these organisms. And then often a virus plus atypical plus pyogenic bacteria, there could be mixed infections as well. Right, and this slide is from Harrison's Clinical Medicine. Now I'm going to show you the common organisms in community-acquired pneumonia in outpatient setting, in a medical ward. Non-ICU means any other ward other than ICU, and then in inpatient. More or less the same bacteria as you will see over here, and they are in descending order of frequency, which means the most frequent are those that are, okay? All right, and there is a comment over here, which is ventilator-associated pneumonia notably develops in approximately 9 to 27% of all intubated patients and carries a mortality rate of 30 to 60%. So it is quite common, 9 to 27% is quite common. And you know that we had to intubate the patients in COVID infections. And that was a virus that could have predisposed the patients to bacterial infections as well. And the mortality rate is quite high. So again, you know, S. pneumonia, mycoplasma, Haemophilus influenza, chlamydia, and then viruses. This is outpatient setting, right? Non-ICU, again, same. Pneumonia, mycoplasma, chlamydia, although chlamydia over here is more common than H. influenza, Legionella pneumophila, and viruses over here. Then even in ICU, because this is community acquired, so again, it is not hospital acquired. If it is hospital acquired, then the organisms are going to be quite different, right? So, and we are specifically or particularly worried about Pseudomonas. So, strep pneumonia, Staph aureus, Legionella, pneumophila, and gram-negative bacilli. This is a little bit different, and H. influenza is also there. So, more or less the same organisms for community-acquired pneumonia in different settings. Now, this is an antibiogram, which, and you know, this is from King Khalid University Hospital. This was given to me by Dr. Thamir. And this is how, you know, we make it. You know, these are the bacterial isolates. They've written number of strains. Actually, it is the number of isolates. For example, E. coli has got about 900 different strains, but in one strain, there could be many isolate. Isolate is something that is isolated from a patient, all right? So over here, you know, you see what they're showing is that, for example, E. coli, we had 3,000, approximately 3,000 isolates. And out of these 3,000, 61% were sensitive to ceftriaxone, you know, CRO is ceftriaxone, okay? They were sensitive. There were others, like this one is resistant to ceftriaxone, Pseudomonas is resistant. And this is some not very common bacteria, Maltophilia. So whatever it is. Then, you know, Salmonella. Salmonella is 100% sensitive to FEP, which is cefepime, okay? And imipenem, 100% sensitive. So these figures or these numbers are showing you the percentage of isolates. For example, this is meropenem, and 99% of E. coli isolates are sensitive to this. 98% are sensitive to imipenem, right? So this is an antibiogram, and this guides us to the treatment regimen for the hospital. You know, this has been prepared. You know, they have been taking specimen, the microbiology lab, from all the patients that were coming with different infections, and they have prepared this chart, and that helps all the physicians to select the appropriate antibiotics, okay? So Pseudomonas, as I said, is resistant, and this one, Citrobacter fruendi or whatever it is, this we don't know. So obviously it is not sensitive, so we will not use it. Okay, the drug has not been. It shows that the drug has not been tested, or it is not indicated in this situation. Right. Now, let us go on to the prognosis. Prognosis depends, number one, on the general health. Good prognosis, previously healthy person with uncomplicated pneumonia, their prognosis is going to be good. Bad prognosis, old age, you know, very common cause of death in old age. Aggressive organisms like Klebsiella, Legionella, or resistant S. pneumonia. We have seen previously that S. pneumonia is resistant, is developing resistance, or is commonly resistant to penicillins. Right. Then comorbidities. What are comorbidities? Can someone tell me? No one? Have you all gone to sleep? Right. Comorbidities means other diseases that the patient has, okay? Respiratory failure and neutropenia, sepsis, you know, all these things, they make the prognosis a bit not very good, okay? In untreated cases, then the mortality is 30%, which is quite high. Bacteria with high mortality rate in community-acquired pneumonias, gram-negative, enteric bacilli, pseudomonas, staph aureus. Okay, so these are the bad ones. They are a bit dangerous. Okay, right. So before we go on to the clinical presentation, we'll take the attendance. Okay, please write your names quickly. You've got only 40 seconds to write your names. If you don't write your names in 40 seconds, you will be marked absent, all right? All right. The 40 seconds are over, and all those who write their names after this, they will be marked absent, all right? Right, so let us go on to clinical presentation. Clinical presentation, you don't have to kill yourself memorizing the clinical presentation. That is the job of the physician. So signs and symptoms: high fever, chills, dyspnea, productive cough, and rust-colored sputum or hemoptysis. These things could be there. Pleuritic chest pain could be there. Tachypnea, tachycardia. So I want you to read this on your own. We have already seen the chest radiographs, and chest radiographs is the job of the radiologist. He will give his opinion on that. We can send some specimen for lab analysis or culture and sensitivity, right? So this you can read on your own, and then let us go on to atypical organisms, right? This is also known as walking pneumonia because the signs and symptoms are not severe. In some cases, the patients, they get so ill that they are lying on the bed, but when certain atypical organisms like mycoplasma, they cause pneumonia, then the patient's condition is not that bad, so he can walk around. The symptoms are so mild that the patient doesn't feel he needs to stay home from work, school, so he or she is walking around. The patient may feel like he or she has cold and doesn't need bed rest. Walking pneumonia spreads through sneezes or coughs, but it spreads slowly. Lots of things can cause it, which include bacteria. Mycoplasma is the most common. Viruses, chemicals, fungi, inhaled food. Inhaled food could sometimes be dangerous as well, right? But if it is not very severe, then the patient will not feel too ill, okay? Patient feels better with a few days on antibiotics. And the cough persists for some weeks after treatment or after the disease has subsided. So it takes some time to go away. Now, risk stratification is important. You must know that. Severity of illness scores or prognostic models can be used to help identify patients that may be candidates for outpatient treatment or inpatient, right? So basically, we use this whether we have to admit the patient to the hospital or give him treatment, which he can take at home, okay? And we have got two models for that. These models are applicable to community-acquired pneumonia, and this is also community-acquired pneumonia. And they include CURB 65 criteria and pneumonia severity index, right? So we'll first look at CURB 65 scoring system for severity of pneumonia. 1 point is given for the presence of each of the following. C stands for confusion or altered mental status, or, disoriented patient, so we give him 1 point. Uremia, if the BUN is more than 20 milligram, below 20, BUN is normal. So above 20, we give 1 point. Respiratory rate is greater than 30 breaths, so that is easy to measure. Blood pressure, systolic less than 90 or diastolic less than 60, right? And then 65 is the age of the patient. If he's older than 65, we give him 1 point. Now, after we have all these results with us. Then we see how many points the patient has. If the patient has 0 to 1 points, then we give him treatment as outpatient, right? If an elderly comes to you above 65 and he has no other symptoms, then you can give him treatment and send him home, okay? Score of 2 means admission to medical ward, and score of 3 or higher means admission to intensive care unit, all right? Now, this is also for your reference. What I'm showing you is that what is the mortality rate as the score increases, curve 65, with 0 score, almost, 0.7%, very low mortality. With a score of 1, mortality is just 3%. When the score goes to 3, it is 17% and 42% with curve score of 4. And if it is 5, then the mortality is very, very high, okay, 57%. Even 42% is very high. And for example, this is a case, this is a patient who was 53 years old. So he's less than 65, will not give him any score. He's not confused. His mental status is normal. His urea is 9.8. We measure in milligram per deciliter, but some people measure in millimole as well. So this is high. So we give him score of 1. Respiratory rate is 20, less than 30. And blood pressure is not less than 90/60, okay? So he has got a score of 1. So what we'll do is we'll treat him at home. Here is another patient, 67 years old, above 65. We give him 1 point. He's confused. His urea is raised 10 millimole, respiratory rate is 30. So he has got 4 points and 42% mortality. And we'll have to treat him and we'll have to admit him into the intensive care unit, okay? Right, then we have this pneumonia severity index, which is a lot more complicated. That is why I've written it for reference only. It's difficult to memorize all the parameters that we take into account, but it is more accurate, okay? So pneumonia severity index, also known as PSI, is a prediction rule for mortality based on characteristics derived from cohorts of patients hospitalized with pneumonia. So whenever a patient came, they would take into account all the factors that I'll show you in the table below, and then they develop this score. So pneumonia severity index has the highest sensitivity for predicting mortality for this H cap, okay? Anyway, what we will, so here are the, and these, it is community acquired pneumonia. So we take into account the age of men and women. They have got different points. You see men above 70 points, and age in years. If it is a woman at the age of 70, a man will have 70 points, but a woman will have 60 points. We minus 10 points. Nursing homes and neoplasia means if he has cancer, liver disease, chronic heart failure, renal vascular disease and renal disease, right? We are giving points for altered mental status, respiratory rate, systolic, fever, pulse, and lots of things, right? So then we calculate the score. So this is for reference only. Same thing written in the form of a table. This is a little bit easier to read. So 5 PSI mortality risk classes, which I will show you over here, right? If the points are from 0 to 50, this is class 1, and the mortality is very, very low, 0.1%. If the patient gets 51 to 70 points, this is class 2, and so on, class 3, class 4, and class 5. So class 5 is very high mortality, 27%, okay? So current guidelines suggest that patients may be treated in an outpatient setting or may require hospitalization. So in both cases, we are trying to make a decision whether to treat the patient at home or to admit him to the medical ward or to admit him to the intensive care unit. Okay, so classes 1 and 2, outpatient treatment. Classes 3, admission to an observation unit for short stay in the hospital. 4 and 5, treatment in the inpatient setting. Could be a medical ward. If he's very serious, you can admit him to the intensive care unit. Okay, right. So their community acquired pneumonia criterion prediction rules like curve 65 pneumonia severity index have been less useful for discriminating between moderate and high risk patients, right? Ward appropriate, although the score has given you some indication, but still, many physicians are confused. Okay, so they use another criteria which is composed of both major and minor criteria, right? These criteria are particularly helpful in identifying those patients who are appropriate for admission to the ICU, but who do not meet the major criteria of requiring mechanical ventilation or vasopressor support. Vasopressor support is needed, obviously, when the patient has developed sepsis, okay? Right, so we'll have a look at the major criteria and the minor criteria. So these are the minor criteria. A lot of them, these first 1, 2, 3, 4 are same as in curve 65, same, confusion, uremia, respiratory rate, hypotension. And in addition to that, we have got oxygen, a fraction of inspired oxygen. What fraction of oxygen is there in the inspired air? We can increase that concentration by giving supplemental oxygen, multilobular infiltrates, leukopenia, the number of white blood cell is low, thrombocytopenia, the number of platelets is low, hypothermia, you know what it is, and need for ventilation. So these are minor criteria, and the major criteria are, and in these situations, we directly admit the patient to the ICU. Invasive mechanical ventilation due to respiratory failure. If the patient has got very high levels of CO2 in his blood, he has got respiratory acidosis, his pH is low, maybe 7.2 or less than 7.2, then obviously is a serious case. And septic shock requiring IV vasopressor support. So these are serious cases, and you have to admit the patient to the ICU. Then we have got certain biological markers. In addition to the above mentioned criteria, some biological markers are there. Now, these biological markers are also important, and they're not a part of the above mentioned criteria, but they are used. It includes C-reactive protein, more than 250 milligram, and procalcitonin, especially promising as a prognosticator or prognostic factor, all right? So we will, this is the last slide we'll do before the break, and then we'll take a 10 minutes break and come back, all right? So procalcitonin is a pro-hormone of calcitonin and part of inflammatory cascade in the immune system. So whenever there is inflammation, procalcitonin levels will increase. Levels have been shown to be elevated in bacterial infections, but not in viral or other inflammatory conditions. Studies suggest values of greater than or equal to 0.25 microgram per liter in non-ICU patients, and levels greater than 0.5 microgram per liter in ICU patients. So may be appropriate to use cutoff points for initiation of antibiotic therapy. So in outpatient, if you measure and the level is more than 0.25 milligram, you start antibiotics. Same if in ICU the levels are more than 0.5 microgram, you start antibiotics, okay? Obviously, you start with empiric therapy. A subsequent drop of at least 80% in the levels may be appropriate to use as a guide for discontinuing. So when they rise, you start antibiotics with these cutoff points. When they fall by 80%, you can discontinue antibiotics. Additional data suggest using a procalcitonin algorithm reduces antibiotic usage, whatever it is. We are not concerned. What you have to remember is that procalcitonin and C-reactive protein, their levels have been given 250 milligram for C-reactive protein, and these are the levels for procalcitonin. They are the markers of inflammation, and they will help you decide whether to start antibiotics or when to stop antibiotics, all right? So we will stop here. I'm going to pause the recording, And when we come back, you should remind me to start the recording, all right? Okay, now we are going to start once again with the lecture, and I hope everyone is back from the break. Now we have got some other scoring models as well, and this is also for your reference. You don't have to go into details. I'll just name them Apache score, Apache 2 score, SAPS 2 score, SOFA, which is used for actually sepsis, but you can use it over here. Then SOAR and models under investigation are PIRO or whatever it is, okay? Smart COP, and these are the ones. And these are the complications of pneumonia that are possible. You don't have to go into the details of these complications. You can read them on your own. A lot of different complications, like they could be serious, like necrotizing pneumonia, empyema, pulmonary abscess, respiratory failure, acute respiratory distress syndrome, lots of things. Sepsis is very dangerous, meningitis, all of these are pretty dangerous complications that could occur as a result of pneumonia. Then differential diagnosis, I mean, you have to look at the respiratory signs and symptoms, but these things could be included in the differential diagnosis of pneumonia. And obviously that is the job of the physician. If you want, you can have a look at them, or you can keep them for your reference, okay? All right. Now, again, lab workup. Lab workup is also not the job of, it's quite detailed, but I've given you just 2 slides, and that is also for your reference, but that's not the job of a pharmacist. The following laboratory tests may not be useful for diagnostic purposes, but are useful for classifying illness severity and admission decisions. So, you've got so many different criteria for assessing the severity of the illness. Okay, you've got that curve 65 and pneumonia severity index, and then you can do lab tests like serum chemistry, the arterial blood gases, and central venous oxygen saturation, complete blood count. So many things you can do over here, right? And these are a little bit more details of the studies that you can keep only for your reference. They will not be included in the examination. So now we come to the treatment part, and all the treatment part is going to be on the exam, all right? So treatment approach, number 1 is to assess the severity. This is the first step in the management, whether you have to admit the patient or give him treatment as an outpatient case. A need for hospitalization. This is one of the most important initial decisions in determining the site or level of care. Options include outpatient medical ward and intensive care unit. Patients who are severely ill and those with signs of respiratory failure, sepsis, or neutropenia must be stabilized. If you have to transfer the patient to a better healthcare facility, then you must stabilize the patient before sending the patient to another hospital on an ambulance, okay? Respiratory support is important. Patient with bronchospasms benefit from inhaled bronchodilators administered via nebulizers or metered dose inhaler, whatever you choose, okay? Patients with mild shortness of breath, only supplemental oxygen with a nasal cannula may be required for ventilatory support. And this is what a nasal cannula looks like. You must have seen this in the hospitals. If the patient is more serious, moderate dyspnea requires high oxygen concentration, such as those provided by a venti mask or partial rebreathing face mask. So this is what a venti mask is. Okay, if you want to give a higher concentration, you use this one. Then continuous positive airway pressure. This is an alternative to intubation or ventilator support. Or, if the patient is very, very severe, he's going into respiratory failure, then you give, or you put the patient on a ventilator. Supplemental oxygen is not sufficient. The patient cannot maintain. So these are the situations in which you will put the patient on a ventilatory support, okay? You put the patient, you paralyze the patient, the muscles, you give a neuromuscular blocking drug, and you give oxygen, and the ventilator is working for the patient, and the patient has to be in prone position. So those are for the respiratory therapists, okay? Patients in respiratory failure or those with COPD who need high O2 concentration may require endotracheal intubation and ventilation. So again, ventilatory support, these patients also fall under the same category. Other management strategies, you have to maintain sufficient fluid balance in the body. You can give intravenous crystalloids for hypotensive patients or those who have tachycardia. Volume depletion may be present because the patients are breathing fast, more than 30 breaths in a minute, so they can lose a lot of moisture. Elderly patients who are already dehydrated and patients with underlying cardiac disease. So in these patients, you have to avoid aggressive fluid resuscitation. Obviously, in cardiac disease, that could lead to heart failure if there is volume overload. Empiric antibiotic therapy, it should initially be broad spectrum, but then you switch over to oral. We'll discuss more of this when we come to sepsis. Community-acquired pneumonia, maximum time from door to antibiotic administration should be 4 hours, or sometimes you say as soon as you admit the patient, you must start empiric therapy with broad spectrum antibiotics within 4 hours. So this is an important point. Corticosteroids are controversial, right? Actually, according to the latest guidelines, they don't recommend corticosteroids, but under certain situations, like if the patient is in septic shock and you think that the adrenal glands are not working normally, then you may administer corticosteroids, okay? Current guidelines recommend empiric therapy with stress dose steroids in patients. So you see they have given a specific group of patients who remain hypotensive despite fluid and pressors, to avoid delay in treatment of presumed adrenal insufficiency, right? It is presumed adrenal insufficiency. So use of corticosteroids, people use that, but it is controversial. Again, this is an antibiogram. A number of bacteria are given over here, and their sensitivities are given. Red means they are not susceptible or less than 59%, which means they're almost resistant. And green, so you can see, these amikacin is a good antibiotic. A lot of organisms are sensitive, and then amoxicillin, clavulanate, a lot of resistance for these. Cefepime, again, a lot of resistance. Ceftriaxone, ceftazidime, a resistance. Even Pseudomonas is not here. But you see these ciprofloxacin, gentamicin, imipenem, meropenem, they are good drugs. Almost just one of these bacteria is resistant. And tobramycin is also good. So this is good for guidance, and every hospital has got an antibiogram like this one that could help you choose the antibiotic. Here's another one. This is from Zambia, Lusaka, Zambia. And over here you see trimethoprim sulfamethoxazole. Almost all organisms are resistant to this one, right? Imipenem is good. Amikacin is very good. Ertapenem is also good, right? So this can help us decide which antibiotic to choose for this therapy. And these are gram-positive and gram-negative. Linezolid is covering all gram-positive. Vancomycin is the best. It covers, and covers 94%, 100%, 95%, very good coverage over here. All right, so this vancomycin, and if you combine with one of these drugs, it could make a good combination. Right, so antibacterial therapy for bacterial pneumonia. Goals of therapy are to eradicate the infection, reduce morbidity, prevent complications. There are very serious complications that I showed you. Empiric antibiotic therapy must be selected with strep pneumonia in mind. Okay, strep pneumonia is the most common cause of community acquired pneumonia. And you know that it is developing a resistance to penicillins because it changes the penicillin binding protein. Treatment of pneumonia depends largely on the empiric use of antibiotic regimens as follows. Directed against potential pathogens as determined by the setting. So I showed you the different settings: community acquired, healthcare acquired, healthcare facility acquired, hospital acquired, ventilator associated. So the organisms were a little bit different. I've got another slide, which again, I don't know whether I have it in this lecture or not, which shows you the recommended antibiotics for different bacteria, all right? Potential for exposure to multi-drug resistant organisms. This is something serious, and other more virulent pathogens prevalent in specific intensive care unit. How do you know that? You know that from the antibiogram that every hospital has, or at least the good hospitals have that antibiogram. Use antibiotics based on lab data as well as clinical response. The possibility of Legionella infection should always be considered when evaluating community-acquired pneumonia. All right. Yes. So here is the slide. You know, I've given the organisms and the first-line antibiotics. Okay. Or here, so for S. pneumonia, if it is penicillin sensitive and if it is penicillin resistant, which means you are getting the minimum inhibitory concentration, which is greater than 2 microgram. Right. So if for this specific drug, even a concentration higher than or equal to 2 microgram is not sufficient. You know, otherwise we have seen that 2 microgram of MIC is pretty good, but in this case, no. Okay. So agents to be chosen on the basis of sensitivity, and these are the alternative drugs that I've given you over here. And this is for your reference because, you know, it's not possible to remember each bacterium and all the antibiotics to which it is sensitive, right? But what we see over here is that for fluoroquinolones are pretty common: fluoroquinolone, doxycycline, and azithromycin, clarithromycin. Macrolides are also common. Trimethoprim, you know, in one of the antibiograms, we saw that trimethoprim is not a good drug for pneumonia because there is a lot of resistance against this drug. Okay. So again, fluoroquinolones and doxycycline is, you know, tetracycline, doxycycline. It's good for atypical, again, tetracycline, macrolide, tetracycline, macrolide. So for atypicals, these drugs are good, right? And these are not very common causes, but still we have these drugs which are there for your reference only. Right, so outpatient empiric antibiotic therapy, antibiotic choices in the outpatient setting should be driven by the presence of patient risk factors, right? So we have got pneumonia severity index, we have got CURB 65, we have got the lab tests, and we have got the patient risk factors. For example, recent exposure. By recent exposure to antibiotics, we mean in the previous 90 days or in the previous 3 months, okay? If the patient has taken antibiotics in the previous 3 months, then we call that a recent exposure. Comorbidities, whether the patient has chronic kidney disease, diabetes, hypertension, whatever, okay? And local trends in antibiotic resistance, which you get from the antibiogram, which is prepared by the microbiology lab, okay? Right, and this is an important slide that I'm going to show you now. First, I'll show you the clinical setting and the empirical therapy. Clinical setting, outpatient. And in the outpatient, we have got 2 types of patients. One is previously healthy, no problem. And the other is patients with comorbidities. For example, COPD, diabetes, heart, lung, liver, kidney, alcoholism, cancer, whatever. So they've got different approaches to treatment. If you are giving outpatient treatment and the patient is healthy and he has not used antibiotics in the previous 90 days, then you give a macrolide or doxycycline, right? It is not, the patient is not in a very bad state. If the patient has used antibiotics within the previous 90 days, then a respiratory fluoroquinolone, which is levofloxacin, is included in that, and gemifloxacin is included in that. So you can give a respiratory fluoroquinolone alone, or an advanced macrolide, which means clarithromycin or azithromycin, plus, so with macrolide plus high dose amoxicillin or advanced macrolide plus high dose amoxicillin clavulanate. So you are using a combination of macrolides and amoxicillin, and you can have clavulanate, or you can give fluoroquinolone alone. And this is in the case when the patient is healthy, outpatient, and he has used antibiotics in the previous 90 days. Now we come to the patients with comorbidities, no recent antibiotic therapy in the previous 90 days. We give an advanced macrolide or a respiratory fluoroquinolone, which is commonly levofloxacin, right, or gemifloxacin. Moxifloxacin is also included. Recent antibiotic therapy, then what we give, again, a respiratory fluoroquinolone plus advanced macrolide plus a beta-lactam. Any beta-lactam you can choose, okay? Then if aspiration is suspected with infection, then amoxicillin clavulanate or clindamycin. This slide is important, all right? You have to know these conditions, at least in these in this slide. Influenza with bacterial infection, beta-lactam or respiratory fluoroquinolone. So just 3 or 4 drugs: respiratory fluoroquinolones, macrolides, and beta-lactams, amoxicillin, and you can add clavulanate with that, okay? Now, what is different is that in case of aspiration, you can have clindamycin over here. That's all. And here you can have a tetracycline, doxycycline as well. So very few drugs, not difficult to memorize. So inpatient treatment of pneumonia should be given within 4 hours of hospital admission and should consist of the following antibiotics. So this is the reference which is given, the antibiotics. There have been some updates as well, but this one is still applicable. For non-intensive care, intensive care patients, choose one option below, beta-lactam plus macrolide, okay? Same as before, again, no difference. But you know, it's IV or intramuscular, IV or oral macrolide. Beta-lactam plus doxycycline. So it is, now we are going to intravenous choices. Okay, obviously outpatient, we cannot give intravenous. Anti-pneumococcal quinolone monotherapy. If the patient is less than 65 with no risk factors for drug-resistant organisms, administer macrolide monotherapy. And if you remember, even in COVID infection, azithromycin was a part of the normal regimen in almost all the patients. Okay, we had antiviral drugs as well, but we were giving azithromycin as well. All right, so these are the drugs. You have to know all these drugs for the examination. And this was 2019. Now, guidelines on community-acquired pneumonia published in New England Journal of Medicine. So what they're recommending is sputum and blood cultures are recommended. And remember, we have to take that before initiating the antibiotics. All right. So empirical treatment for MRSA, Pseudomonas aeruginosa. So we have to take this culture and send for culture and sensitivity. Then recommendation for macrolide monotherapy, not combination. Monotherapy has been downgraded. Previously, it was a strong recommendation to give azithromycin alone, but now it has been downgraded. You still give it, but it is no longer a strong recommendation. Now, corticosteroid is not recommended. Okay, the guidelines generally recommends against corticosteroid use. Then the combination of beta-lactam and macrolide is still acceptable. We have seen that in the previous slide. We are combining azithromycin or clarithromycin or whatever with amoxicillin, clavulanate, and you can combine with fluoroquinolone, but this combination is superior to lactam and fluoroquinolone combination, right? So this slide is also included in the examination. Now previously we looked at the outpatient setting, now inpatient. And let me remind you once again that antibiotic must be initiated within 4 hours of hospital admission. So medical ward and intensive care. Again, we divide the patient into recent antibiotic therapy and no recent antibiotic therapy. Now we are going to IV drugs. Okay, that's the difference, the most important difference. IV, IM. And remember, when you initiate a patient on IV or IM or parenteral therapy, you must review the patient within 48 hours. I'll tell you more about this in the sepsis lecture. We have a certain algorithm for changing, or we look at certain factors to change the therapy from IV to or parenteral to oral. Okay, so IV respiratory fluoroquinolone, again, that is levofloxacin and moxifloxacin and gemifloxacin. They can be given alone or advanced macrolide plus IVIM beta-lactam. The treatment is the same as we saw previously. Previously, in no antibiotic therapy, we had just macrolide and tetracycline, right, in this group. But here we are going to IV and the combination. In the previous, in outpatient, we had a combination of macrolide plus beta-lactam if there was recent antibiotic therapy. Now here, IV respiratory fluoroquinolone alone, just like this one, IV or per oral macrolide plus IVIM beta-lactam, same thing. Okay, maybe the dose could be more aggressive in cases of beta-lactams. Now, Pseudomonas in intensive care. If Pseudomonas is not an issue, then again IV beta-lactam plus either advanced IV or PO macrolide, same treatment, no difference. IV respiratory fluoroquinolone, not combination, it is or. Either you have this combination or IV respiratory fluoroquinolone, right? And monitor the patient. In the difference between, although you are giving the same treatment, but the patient is more serious and you have to monitor the patient more closely. Pseudomonas infection is not an issue, but the patient has allergy to beta-lactam, right? Then again, it is fluoroquinolones and clindamycin. No new drugs, same as previous. Now, Pseudomonas infection is an issue, right? Pseudomonas infections must be treated as admitted cases. Anti-pseudomonal, beta-lactams plus IV amino. So you are combining, you are giving aminoglycoside is an anti-pseudomonal drug. And you have got so many others like ceftazidime, cefoperazone, you have piperacillin. They are all anti-pseudomonal drugs, okay? So you are giving a combination. Actually, you are giving two anti-pseudomonal drugs plus an anti-pneumococcal fluoroquinolone or fluoroquinolone or macrolide. So broader spectrum antibiotics. And now what you have is Pseudomonas infection as well as beta-lactam allergy. Okay, so over here, anti-pseudomonal penicillins or cephalosporins will not be given. So you go to aztreonam and you go plus aminoglycoside plus IV levofloxacin, very aggressive treatment, all right? So not difficult, you read it a few times and you will remember it. Now, empiric therapy for hospital-acquired pneumonia went to cover for methicillin-resistant Staph aureus if there is prior intravenous antibiotic use, intravenous, right, within 90 days. Hospitalization in a unit where greater than 20% of Staph aureus isolates are methicillin-resistant. So you saw that the antibiogram that shows you what percentage of isolates are sensitive or resistant. Okay, so that's how you will know what percentage is resistant. Then patients who need ventilatory support in hospital-acquired pneumonia, in patients with septic shock. So you will cover methicillin. What will you give for methicillin-resistant Staph aureus? Can anybody tell me? Which antibiotic? Okay, there is something on the chat, and Vanco is the answer, which is the right answer, and linezolid could also be added to that. Okay, so when to give two anti-pseudomonal antibiotics for increasing the likelihood for pseudomonas or other gram-negative infection, factors increasing the likelihood. Okay, so we have seen that we are combining beta-lactams, piperacillin, ceftazidime with aminoglycosides. Okay. And in those patients who are high risk for mortality, very ill, very old patient, okay, patients in septic shock. So these are the patients where you will give more aggressive therapy and you will give two anti-pseudomonal antibiotics. Okay. Now we go on to targeted therapy. You have reviewed the patient after 48 hours. These antibiotics take a little bit of time to be effective, 48 to 72 hours. So you review the patients. The patients should improve in 48 to 72 hours. If he doesn't improve, then maybe we have a problem with the antibiotic. So you give targeted therapy means now narrow spectrum therapy, okay? Targeted against a known bacterium. So once the culture and susceptibility results are available, de-escalation to targeted therapy should be done. De-escalation means switching over to oral medications. Now, can intravenous aminoglycosides be used as monotherapy in pneumonia? No, they cannot be used. Why? So that's what I have shown you here, because their penetration of lung penetration is poor and low antibiotic concentration in the epithelial lining fluid of the lung, right? So epithelial lining fluid means mucus. And then antibiotic options, this is a table. The only thing that you have to understand in this table is, I'll tell you that in a minute, but see, for gram positive, we have got vancomycin and linezolid over here, right? The doses are given over here. This is a good table. I think you should know it. We have drugs for gram negative, piperacillin, tazobactam, cephalosporin, cefepime, ceftazidime, carbapenems, and monobactam. Good table, you must know this, okay? So this will be included. I have not written for reference only. Then gram-negative antibiotics with anti-pseudomonal activity, non-beta-lactam based, okay? Fluoroquinolones, aminoglycosides, and polymyxins. And this is the last treatment option that we have. If this doesn't work, then we are in a bad situation. Then inhaled antibiotics, colistin or aminoglycosides should be used in combination with intravenous antibiotics. When to use? When a gram-negative pathogen is only susceptible to colistin or aminoglycosides. How will you know that? You will know that from the culture and sensitivity. Last resort for patients who are not responding to intravenous. You know, a lot of patients die. Why do they die? Because they're not responding to any antibiotic, but we try our best. We start with empiric therapy. We get the results of culture and sensitivity. If the bacteria grows, we review the patient after 48 to 72 hours. We see the response, and then we might have to change the antibiotics. Advantages, it improves clinical cure. Disadvantages, cost and inconvenience. There's no difference in mortality, drug resistance, or adverse effects compared to intravenous antibiotics alone, right? So these were the inhaled antibiotics. And now we go on to aspiration pneumonia. And after that, we have got ventilator-associated pneumonia. I think we have got half an hour more, and we will complete this lecture hopefully in time. Right. So aspiration pneumonia, patients with severe periodontal disease, portrayed sputum, portrayed means bad smelling, or a history of alcoholism with suspected aspiration pneumonia may be at greater risk of anaerobic infection. One of the following antibiotic regimen is recommended, which is piperacillin tazobactam, imipenem, and clindamycin or metronidazole plus respiratory fluoroquinolone plus ceftriaxone. Okay, so methicillin resistance, we have already seen that vancomycin or linezolid may be added to the regimen. So the treatment, if the patient is serious or pneumonia is severe, then obviously the treatment becomes a little bit more difficult, okay? And when the organism's identity and antibiotic sensitivities become known, medications can be adjusted according to the result of culture and sensitivity. Now we look at the common pathogens for ventilator-associated pneumonia. We have got gram-negative and gram-positive Pseudomonas is there, which is pretty serious. E. coli, Klebsiella, and Acinetobacter species. So all different from community-acquired. Gram-positive Staph aureus is there, okay? Treatment principles, generally initial therapy is driven by local susceptibility patterns and hospital protocols, which are based on antibiograms. Combination therapy is used upfront, which means you start with the combination therapy for multi-drug resistant organism. The narrow spectrum therapy is based on culture and clinical condition. When to give two anti-pseudomonal antibiotics? When there is a risk factor for multi-drug resistant VAP or patients in units where greater than 10% of gram-negative isolates are resistant, okay? So we have to look at the percentage of resistance. So we choose two anti-pseudomonal. I hope everything is clear. Here is again an example of an antibiogram. It shows that E. coli, we had, I think this is the one I showed you previously as well. It has been repeated, okay? Yes. So this one is repeated by mistake, but anyway, yes. So this slide is also good. You don't have to memorize this, but you see gram-negative bacilli, amikacin, cefepime, their coverage, good coverage, and amikacin 96% coverage, meropenem 91%. So all these drugs are good for gram-negative organisms. Right, so key points with antibiotics: administer the appropriate dose and switch to PO when able to do so, oral therapy. Use combinations if multi-drug resistance is likely. Avoid inadequate therapy. Complete the days of the therapy, 7 days IV for at least 48 to 72 hours, switch over to oral if necessary. There is a criterion for switching over to oral therapy. If that criterion is fulfilled, then but you must continue the therapy for at least 7 days. Monotherapy, once the culture and sensitivity is back. Aminoglycoside monotherapy should be avoided, that we have already seen. Duration of the therapy is at least 7 days. It could be more as well. Narrow or adjust antibiotics based on culture and sensitivity. Now, supportive measures, we are coming almost to the end of the lecture. Analgesia, antipyretics, chest physiotherapy, intravenous fluids, or if there is fluid overload, we can use diuretics, monitoring pulse oximetry. You know, there was a lot of factors that I've shown you previously as well. Oxygen supplementation, positioning the patient to minimize aspiration risk. Maybe you will prop him up a little bit. Bronchodilators, N-acetylcysteine as a mucolytic drug, suctioning, bronchial hygiene. So you see, it's a team that is working. The respiratory care physicians and specialists are also working over there. Chest physiotherapy, suction of secretions, mechanical ventilatory support with low tidal volume, or sometimes, it depends, the chest physician has to decide how much oxygen to give, okay? Proper nutrition and early mobilization. This is important in all the drugs. Nutrition is very important. So these were the supportive measures, and then you have to look for clinical resolution. The patient should respond ideally to antibiotic therapy within 48 to 72 hours. With appropriate, the right antibiotic therapy, improvement in clinical manifestation should be observed in 48 to 72 hours. Because the time required for antibiotics to act is 48 to 72 hours, so you should continue it for 72 hours. But if you see that within 24 hours or more than that, the patient's condition is deteriorating instead of improving, then you have to reevaluate your antibiotic therapy. With pneumococcal pneumonia, the cough usually resolves within 8 days. Crackles, that you hear with a stethoscope, they may remain there for some time, okay? Like you've seen that in atypical, the cough remains there for 2 to 3 weeks. Now, the last 2 or 3 slides, prevention. You have to give vaccines for immunocompetent adults aged 65 years or older who have not previously received pneumococcal vaccine. These are the vaccines, pneumococcal conjugate vaccine, pneumococcal polysaccharide vaccine, right? This is 13 valent, which means it has got antibodies against 13 different types of strains, 23 different types of strains, okay? For children 2 years or older who are at high risk of pneumococcal disease, you should vaccinate those children. You should vaccinate old people, immunocompromised children, or children with functional or anatomic asplenia. Asplenia means the spleen is not there. So should receive a second dose at 5 years, right? So 2 years and 5 years. So here's pneumococcal vaccine 13 valent, and this is pneumococcal vaccine polyvalent. This is 23 valent, okay? And then prevention of community acquired pneumonia, administration of influenza vaccine. Every year you have to give influenza vaccine to elderly people. In fall means, autumn. Autumn is another word, August, September, something like that, okay? That is fall. Or winter risk of viral influenza, which decreases the risk of bacterial superinfection. This vaccine is especially important in patients who are elderly and with comorbidities, and this is the flu shot that you have. And that is all for this lecture. All right, if you have any questions, you can ask. I thought it will take a long time, but because Myrna said that today's lecture time is only 2 hours, usually it is 3 hours, so I cut the lecture short, but this is sufficient, You must know everything that is there in the lecture. And this is the minimum that you should know about pneumonia, okay? Because my other lecture on pneumonias is more than 100 slides. Okay, so if you have any questions, then you can ask me. Otherwise, Uthef has already thanked me. Should we take an attendance or not? All right. Please write your names and then we'll say good night to each other. Right. Thank you very much. And Myrna will give me the attendance. And that's all for today. So I will see you next time, hopefully.